Hello everyone, I hope you're safe. This is Dr. Nerd. In this video, I'll give you an overview on cardiology. Most of the things I will talk about here will be covered in details in upcoming videos, so don't be overwhelmed. So let's just get started. Now, I will start off by talking about the layers of the covering of the heart, because the heart is quite an important organ, so it should be covered. And whenever we talk about serous covering of an organ, we give this example of you pushing your fist against a balloon, and which will create a space and two layers, one that's touching your fist and the other one. And that's exactly what this diagram shows. So the myocardium is being pushed against this serous sac, which created this space, this layer, and the outer layer. Now, if we take a cross section here, we can see myocardium innermost, then visceral pericardium, which is in fact attached to the myocardium, you cannot separate it, and then there is a space in which a fluid is found. It's called the pericardial fluid, and it's there to reduce the friction of the pumping heart. And then there is the parietal pericardium, which is attached to the fibrous pericardium. The fibrous pericardium is an additional layer specifically found in the heart. Now, when we talk about diseases regarding the pericardium, there are only two diseases, pericarditis and cardiac tamponade. Pericardial effusion is just one of the consequences of pericarditis. Now, what is pericarditis? Pericarditis is in the inflammation of the pericardium. And because of inflammation, the fluid may increase a little bit, which is pericardial effusion. Now, the typical clinical presentation of pericarditis is someone in young age, a male or a female, in their 20s, for example, and they are complaining of chest pain that increases when they lean forward. And the reason why it increases when they lean forward is because you can imagine that the covering of the heart is inflamed, and when someone leans forward, this heart could hit or touch the chest wall, which could be very, very painful. Now, when you do ECG, you will see diffused ST segment elevation. Now, we'll have a separate series on ECG, but just keep that in mind. For cardiac tamponade, what is cardiac tamponade? Is severely increased amount of fluid in the pericardial space. Severely increased. That it creates pressure that the muscle of the heart can no longer pump. And it could be seen in severe pericarditis or in perforation of in one of the heart walls. And it could be detected by this sign, Beck's triad. So, hypotension, jugular venous distension or increased jugular venous pressure, and muffled heart sounds. You do not want to confuse this with tension pneumothorax triad, which is hypotension, jugular venous distension, and absent heart sounds. So this one is for cardiac tamponade. The other one with absent heart sounds is for tension pneumothorax. When you do ECG, you will see something called electrical alterance, which means there will be different sizes QRS complexes. So this one is kind of small, this one is bigger, this one is very big, and then a smaller one. So this is something you will see on ECG, something similar to this you will see on ECG if someone has cardiac tamponade. Now, for the location of the heart is found in the middle, in the midline, shifted to the left. Specifically, 2/3 of the heart is on the left side, 1/3 of it is on the right side. There is a base of the heart and apex. And there is this term which is apex speed. What is apex speed? When you place your palm on the chest of the patient or on your own chest, there is this location where you will feel the beat the most, which tells you where is the apex of the heart. Normally, it should be in the 5th intercostal space on the left side, mid-clavicular line. But in patients who have hypertrophy of the heart, it could be shifted towards the axilla. Or in patients who have COPD, it could be somewhere down here. So it tells you a little bit about the pathology of the heart without doing any radiological testing. Now, for the surfaces of the heart, there is the diaphragmatic surface, which is attached to the diaphragm, which lacks the fibrous pericardium that we talked about. The fibrous pericardium is absent in the diaphragmatic surface. There is the sternocostal surface, which is just behind the sternum, and there is a right and left surfaces. But when clinicians talk about MI or ischemia, they will say something that like left wall infarct or right wall infarct or anterior wall infarct or something like that. What they are talking about is the walls of the left ventricle, not the walls of the heart. So just keep that in mind so it doesn't create any confusion. The heart contracts in a spiral fashion, in a spiral contraction, which means the apex contract first, then the base. If you want to think about it, you can say it contracts from the bottom towards the top. Now, the cardiac skeleton is we know that the heart is muscular, it is not that hard, but the cardiac skeleton is the tough part of the heart that all the valves attach to. It supports the valvular tissue. Now, I will talk a little bit about the circulation and a little bit about right heart failure versus left heart failure. So in the circulation, there is the superior vena cava, inferior vena cava, and the coronary sinus, which empty the blood into the right atrium. And there is something here called the crista terminalis. In the upper part of the crista terminalis, the SA node is found. So the blood will come from the superior vena cava, inferior vena cava, and the coronary sinus in the right atrium, which is entirely smooth, into this tricuspid valve. There is the sleevelet, the chorda tendineae, and the papillary muscles. The anterior papillary muscle in particular has this trabeculae, which is called the septomarginal trabeculae, which is attached to the septum of the heart. And in this septomarginal trabeculae, or the moderator band, the right bundle branch runs in it, which is part of the conduction system. So if there is an injury of this septomarginal trabeculae, there will be the conduction system of the right heart will be affected. Now, this is the right ventricle, which is entirely rough, except for this part, which is called the conus. Now, blood travels from the right ventricle through this semilunar valve, the pulmonary trunk, into the lungs, which this is the left pulmonary artery, which carries deoxygenated blood. Now the blood will get oxygenated and will return to the heart via these veins, which are four, two on each side, and will enter to the left atrium, which is entirely smooth. It will go through this bicuspid or mitral valve into the left ventricle, which is way thicker than the right ventricle. Then the left ventricle will push the blood into the outlet through the systemic circulation. Now let's talk about the right heart failure. So the right heart fails when there is increased resistance in the lungs, for example. So any point passing this point, if there is an increased resistance there, which will lead to failure of this heart. So if there is, for example, pulmonary edema, there will be backflow of blood to the right heart into the superior and inferior vena cava. It will lead to increased venous pressure, jugular venous pressure, and it may also lead to decongestion of the liver. The left heart fails when there is an increased resistance in the systemic circulation, anywhere in the systemic circulation, for whatever reason. So if there is increased systemic circulation, if there is an increase in the resistance in the systemic circulation, For whatever reason that may lead to increase in the resistance in the systemic circulation, it will lead to the failure of the left heart. So there will be backflow to the left heart, into the atrium, the left atrium, into the lung, which may lead to pulmonary edema and eventually failure of the right heart as well. So left heart failure could lead to a right heart failure, but not the opposite. Now I'll talk very briefly about the physiology. Now there is this thing which is called pressure volume loop, which is explained in this diagram. So on the y-axis we have the left ventricular pressure. On the x-axis we have the left ventricular volume. Here we are talking about only the left ventricle. Now it has 5 phases, and which we're going to be talking about here. Now the first phase is the isovolumetric contraction, in which the mitral valve is just closed and the aortic valve is yet to open, and the left ventricle is contracting, which will increase the pressure in the left ventricle. It will reach to a point where the aortic valve will open and the ejection phase will start. So it will be ejection of the blood, which will increase the aortic pressure to 120 or something. Then the pressure will start to decrease until the aortic valve closes. Now the aortic valve is closed, the mitral valve is yet to open, which is the third phase, the isovolumetric relaxation. Now there will be relaxation, which means the pressure will decrease. Then the mitral valve will open. There will be 2 phases, the fourth and the fifth, which is the rapid filling phase and the reduced filling phase. Then the mitral valve will close and the cycle continues. Now I'll talk very briefly about the heart sounds. S1 is heard when the atrioventricular valve closes. S2 is when the semilunar valve closes. The closure is always louder than the opening. Now some situation S3 will appear. S3 could be pathological and could be non-pathological. S3 could be heard in pregnancy or in young adults, and also could be heard in heart failure. Now S4 is always pathological, and it could be heard in patients who have non-compliant left ventricle. Now a little bit about the auscultation. They will tell you that the best location to hear the aortic valve is the second intercostal space, right sternal angle. Pulmonary valve is best heard at the second intercostal space, left sternal angle. Tricuspid is best heard in the fourth intercostal space, left sternal border, and bicuspid in the fifth intercostal space, left side midclavicular line. But what is more important than this is the murmurs or the abnormal heart sounds. 2 things you have to know about murmurs at this point. Most common vulnerable valves is the aortic and the bicuspid or the mitral valve. Hence, they are the most common to produce murmurs. Now there is this term which is quite important, and I underlined it, which is systolic murmurs versus diastolic murmurs, meaning murmurs that are heard during diastole and murmurs that are heard during systole. Now, semilunar valves stenosis murmurs are better heard during systole. AV valves stenosis are better heard during diastole. This situation is exactly the opposite in regurgitation. So if there is semilunar valve regurgitation, this murmur is best heard in diastole, and if there is AV valves regurgitation, this murmur or murmurs will be heard during systole. Now this brings us to the end of the video. These are the resources. I hope this wasn't a tough video. As I told you, it is an overview. Don't be overwhelmed. And yeah, and as the Truman once said, In case I didn't see you, good afternoon and good evening and good night.